Hello and welcome to the AHF podcast. I'm your host, Joe Schwab. Today, I'm excited to speak with Dr. Kristoff Corten, a Belgian orthopedic surgeon who really embodies the intersection of clinical excellence and technological innovation. Dr. Corten is not only known for his surgical expertise in hip procedures, but also for his entrepreneurial spirit. He's designed several groundbreaking products, including the gripper system and the EasySuit range that are transforming operating room workflows. But today, we're going to focus primarily on one of his latest ventures, HipCloud. This data-driven platform represents a real paradigm shift in how we can approach hip care, using predictive analytics and personalized treatment pathways to potentially optimize outcomes for each individual patient. We'll also dive into Dr. Corten's philosophy on balancing the demands of clinical practice with innovation and entrepreneurship, his approach to teaching anterior approach workflow efficiency, and his role in the European Anterior Hip Meeting. So let's get started. Kristoff, welcome to the AHF podcast.
Thank you, Joe. It's an honor for me to be here on the podcast, and I think it's a great initiative. So yeah, I'm excited to have this conversation with you.
Tell our listeners a little bit about HipCloud, what it is, and what problem maybe you were trying to solve when you developed it.
Yeah, well, HipCloud is basically an AI-driven platform that allows me to talk to my patients, to consent my patients, no longer by guesstimating the outcomes, but by actually being able to predict more precisely the likelihood of having what we call a forgotten hip. We know that one of the advantages of the anterior approach is that because we save the soft tissues, that the forgotten hip outcome is something that we reach very often in many patients. However, we also have to acknowledge that still there are some patients that are not doing great, that are not having this forgotten hip. Now the question comes, what can a patient expect? Are you in that sort of patient that can expect to have a forgotten hip? Or do you have to be realistic that maybe a forgotten hip is not really what you can expect? And therefore, we no longer guesstimate, but we really predict the probability of certain complications. And for us, a complication is not necessarily a surgical complication, but also having, for example, a postoperative lumbalgia or a sciatica. For the individual patient, this is a complication because he or she never had that sciatica. And although me as a surgeon cannot do anything about it, it's not my fault, but when they develop a sciatica, it's really a painful episode in their life. And we now can predict what the likelihood is that they will develop sciatica postoperatively. And this is a very easy example, but obviously also we are able to predict what the likelihood is that they would have, for example, a periprosthetic fracture or any other surgical related complication.
So tell me a little bit about walk us through the patient journey for this. Is this something you do in the first clinic visit when you're discussing a hip replacement with them? Do you put the data in right in front of them? How do they get to their personalized treatment pathway?
That's a great question. I think one of the issues that I had, that I was faced with is actually efficiency and amplification of what we do in the clinic. We as surgeons, we focus a lot on the core, and our core is obviously the operating room, and we work a lot on efficiency there. And when you're able to manage to deal with a lot of patients in the operating room, you also have to be able to manage with those patients outside the operating room, which is obviously our clinic. And I was meeting my limits there, and we were back in 2017 that I realized I no longer can expand my practice because simply I cannot see all those patients preoperatively, postoperatively, and making those decisions for surgery. I didn't have really enough time to make those decisions in certain complex cases. So I realized that I had to increase the efficiency in my clinic. Now, that was a big challenge, because how are you going to do it? Because typically a patient comes for a doctor and says, doctor, I want you to look at my hip and want you to decide on how we're going to deal with this problem. So that was a first problem. So how do I, as a doctor, how am I able to expand my clinic without really leaving the clinic, in terms of I still need to be there. So, and I need the patient to feel that I am there, although I do not have to talk to every patient about 30 minutes. So how do I do it? So what I did was I started with the hip coaching concept. So I hired Stan Rosa, who was our head hip coach. He's a physiotherapist. And I said, Stan, what I want you to do is I want you to follow my clinics, and I want you, as a physiotherapist, to look at my patient from a physiotherapeutical insight. And I want you to give me feedback. What and how could we approach those patients differently? And how could we manage them differently in terms of conservative treatments? So then we started with Stan, who he started developing certain pathways. So a patient with greater trochanter bursitis has a different pathway from a patient with osteoarthritis, for example. A patient with DDH or with FIA had a completely different pathway. So, and over the years, we hired more and more hip coaches. And I was having a team of 5 to 6 hip coaches who were seeing all my patients, and I was just there talking to the patient, making the decisions, but the trajectory of the patient was followed by the hip coach. So every hip coach was a guide to each patient. So what we did then is we were able to personalize the trajectory of the patient and follow up that personalized trajectory. And all these data of more than 6,000 patients who were followed up in a personalized way were put into one big data lake, an AI-driven data lake, which is called the Hip Cloud. And all of this was done by our hip coaches. And then we identified parameters that were of utmost importance to define outcomes and to define the best trajectory for conservative treatments. And now we do it the other way around. So you, as a patient, come to me, I identify your parameters, we put the parameters into the AI-driven platform, and AI says, you know what, based on all our patients that are collected over the years, this should be your best personalized pathway. And now the Hip Cloud takes over those personalized pathways of the patient. The hip coach uses the Hip Cloud to communicate directly with the patient, and then to decide along with the patient together what is the best timing for surgery. Now, when you as a patient come into my clinic, I see you, I say, okay, this is your diagnosis. And from here on, your hip coach is going to be your guide, and you no longer see me unless in the OR. And outside the OR, you no longer see me unless you have a complication. So what happens is, I am the starting point, I do the surgery, and if you have a normal trajectory, the rest is done by the hip coaches. And by doing this, we have seen that, first of all, our conservative treatments have been upgraded dramatically, with extraordinary results also for patients with hip arthritis. So conservative treatment was improved. And because we are, with the Hip Cloud, always in contact with the patient can chat, and we know exactly where the patient is. The patient feels that we are nearby to them, although not physically, and that he or she, when she says, now I have a real terrible episode of pain, they contact us through the Hip Cloud, and day after they are in the clinic with the hip coach. And then the hip coach decides, okay, you need to see the doctor or not, because the hip coach perfectly knows the trajectory of the patient. So what we managed to do is to still have a personalized care path of the patient where I am involved, but I have people around me who follow those thousands of patients every day. And when a patient says, okay, now it's time for me to go to surgery, the team exactly knows what to do, and I will see the patient in the OR without really having to see all those patients. So with the hip cloud, I think we are reaching a moment where we amplify the clinical performance of the physician.
So the original data set for Hip Cloud was based on these 6,000 patients that were treated through this hip coaching process. Does the current set of patients sort of give continual feedback to Hip Cloud? Meaning, is the AI predictive model changing over time?
It is. It is. So that was a starting point, and I think the model, it's only 6,000 patients, and so the model will now be continuously be improved. But now we have, with the European Hip Center, we have now 4 other surgeons who are also putting in their data into the same model. So, and I think we are now reaching the point to which you, Joe, for example, would say, okay, I also want to use the hip cloud and a generic basis of the hip cloud. And we are reaching the point that you will use that hip cloud without having to have hip coaches. You don't have to have hip coaches. And the patient will put in data automatically, and you will develop your personalized hip cloud based on the model that is already there. So, for example, we're not there yet, but we are reaching that point because 4 or 5 other surgeons are putting in their data as well. So we see also, is there a surgical interference with the data? Because up till now, it was my personal data. And I think what we want to reach is that I will be able to provide to you the prediction model that is your personal prediction model. We do not have the intention to benchmark you. That's not what we want to do. We want to help you based on the AI model that we develop. We want you to develop your personalized model based on, let's say, 100 surgeries or 100 patients. So not an extensive amount of patients. Because the model, that's the nice thing about AI. You don't need to have 6,000 patients. Once the model has been developed, you can go with a smaller subset of patients to reach the same outcome that I have developed now, needing more than 6,000 patients. So the model helps you as a surgeon to create your personalized prediction outcome. So, for example, I think I do anterior approach off the table. You do it on the table. I think this could be a factor. Maybe yes, maybe no. Could be different. So you can use the hip cloud, let's say within a year or a year and a half. You can use your hip cloud. In the beginning, the data or the prediction that you will use would be my prediction, which is not necessarily the correct prediction for you. But after, let's say, 100 or 200 patients that have been put into the model would be able to say, okay, Joe, these are your predictions for your patients. And from now on, you can use your own prediction model.
And so is the prediction model sophisticated enough that it might even identify for you changeable risk factors or changeable behaviors or changeable parameters to help a patient potentially avoid a negative outcome or a complication?
That's a great question. That's actually, to be very honest, for me, the biggest leap forward since I've been using that prediction model. Because we all know a patient comes in front of us and says, doctor, after 2 years or after 1 year or whatever, I no longer can have this pain. I want you to help me. We send them over to a physiotherapist, which we don't know what he or she will be doing. Second, we give an injection. Patient comes back after 3 months. Doctor, it's excruciating pain, but the patient has only DDH with, let's say, very minor arthritic changes. We do not want to operate on those patients because as long as there's not end-stage arthritis, you rather do not want to operate on a patient. That's what we don't want to do. But the patient is having a lot of pain. So we're doctors and we want to help the patient. And we understand that the trajectory of the patient has taken a long time. And but we feel that this patient is probably not the best candidate for hip replacement surgery simply because the hip is not worn out. Well, with the prediction model, I can now show to the patient, say, look, you do not have end-stage arthritis. You have DDH, and we know from our data from previous patients that you only have 30% chance that you will have a forgotten hip. Are you willing to go through a total hip replacement procedure knowing that you only have 30% chance that you will do fine? Or, and we have the same prediction model for conservative treatment, if you follow our personalized conservative treatment trajectory, you have 60% chance that you will be better after 3 months. So what do you want? What kind of decision do you as a patient want to take? Because I know you're having pain, but the data tell us that you're likely not going to be the perfect patient. And then what I then see is I see completely change in the mindset of the patients. They take ownership of their situation and say, look, I'm going to do everything I can not to have this surgery. Now, after 3 months, that's very important. We also tell them we're not going to go for physiotherapy for another year. No, that's not the goal. Let's go for 3 months and then we make a decision together. And if you're not doing well, we might go for surgery. And since I do this, I have much more impact during clinic in those difficult cases. I much more impact on the decision, and I create a real ownership of the patient because they decide now based on data why or not they would have to go for surgery. That's one thing. Second, postoperatively also, we have patients who develop some groin pain. And groin pain does not necessarily have to be psoas impingement or whatever, just groin pain. Well, I use the same prediction model and show them, look, what we see in that female patient with DDH, that about 15% of them do have groin pain, which is not necessarily a groin pain to a level that they can't function. But for the patient, they feel that the groin is not perfect. And I said, look, this is part of your disease, I'm afraid. 15% of your peers have the same problem. So it also helps me postoperatively to explain that some non-optimal outcomes do occur after surgery. And these are mainly soft tissue related problems.
You mentioned initially about the hip coaches and their ability to essentially provide data into this system. And originally, it was sounding to me like Hip Cloud would be a way to replace the hip coaches, but they seem to be an integral part of that ecosystem, even with Hip Cloud in place. Can you talk a little bit about what their role is under the current system?
Under the current system, well, so when we go back to the reason why I started all of this, I wanted to amplify my capabilities in clinic, and therefore I have a full team of coaches, and but they use the Hip Cloud as the instrument that is used for every patient. So if you really want to amplify your capabilities in clinic, I think it is very useful to use hip coaches. Hip coaches can be trained very easily because those physiotherapists, they pick it up very quickly. So and we are even thinking in the European Hip Center to allow fellowships for hip coaches. So they come over to us, they come over for a couple of weeks, and then they go home to their surgeon, and they bring the same knowledge to the surgeon along with the Hip Cloud. So that is what, in case you want to amplify your clinic, or you want to increase your clinic, that's one reason why you would use hip coaches. But if you just say, look, no, I'm happy, I just want to move on the way I do it, then you can also use you can use the Hip Cloud, and how would I say? You can perfectly use Hip Cloud, but it's more a generic kind of Hip Cloud because somebody has to put in your data. And let's be honest, many surgeons do not have time to do that. Yeah. But you would be able to use a more generic Hip Cloud, on your own.
So I want to shift topics just a little bit because you're simultaneously a practicing surgeon, but you're also a really active innovator and entrepreneur who we have known through the Anterior Hip Foundation, presenting multiple products and working with a number of companies. How do you really balance those two, what I would call demanding roles?
First of all, you cannot become an entrepreneur. You are an entrepreneur. So it's part of being yourself. And it's like, for me, the same thing as you cannot become a surgeon, you are a surgeon. And if it's in you, it will come out. And the only thing you have to do then, you have to have the guts to just not look at how much time will take of your personal life. You just, because it's in you, it's the energy. You want to change things, you want to improve things, and then you start running, and you run, and you keep on running because the energy is there. But I have to say, in the beginning, I combined it with full clinical practice, and then also being the entrepreneur on top of things in the evening, in holidays and everything. But I have to say, I have downsized my clinical practice now to about 80%, I would say, and 20% no, let's say 75% clinical and 25% more entrepreneurial, because I feel now that if you want to really keep on innovating, you have to really make time for that. But a strong message that I could give to all those surgeons who want to be an entrepreneur is just make sure that you build a complementary team around you. Don't think that you should be a CEO. No, being a CEO, it's like being a surgeon. Your CEO doesn't want to be the surgeon either. So make sure that you build a good team around you, but that the vision, the mindset, the dynamics come from you. Make sure you have a CEO who does all the operational stuff. And you don't have to care about that. And I think if I look back to that, Joe, I think that is where we made the difference in terms of I was still a surgeon. I was talking to my peers, but everything around the businesses was done by people who knew it much better than I did. And at the end, we are surgeons and we're not businessmen. Well, and if you are a businessman, then you shouldn't be a surgeon.
Right.
So, well, that's the way I look at things. So hip clouds for the same thing. So with the hip clouds, I say, you know what? I want you to be my CEO of the hip cloud company. This is your role. I will bring in the ideas, I will bring in the data and whatever, but you're going to run the company. I'm not going to do it. In none of my companies, I am the CEO. I'm only in the board, but I do not have an operational function.
If you're doing anterior hips, or if you're thinking about it, let me just say this. AHF events are different. You won't be sitting in the back of a dark room watching slides all day. The content is practical and technique driven. And the AHF is a real community. You can stop anyone in the hallway and ask, how are you handling this exposure? Or what are you doing in this revision? And they'll walk you through it, because that's the culture. If you're early in your anterior experience, there's a fundamentals track focused on technique and complication management that you can use Monday morning in your own OR. But if you're extending into complex primaries or revisions, we're already there, having honest conversations about what works and what doesn't. And we have pre- and post-meeting anterior hip labs for every stage of learner. There's something for everyone. More importantly, it's a group of surgeons serious about continuous improvement. AHF 2026, entitled Consensus and Controversy, is June 5th and 6th. You can see the program and register at anteriorhipfoundation.com. If you've been thinking about coming, come. You'll leave better than you arrived. I'll see you in Nashville. Was there a specific instance that motivated you to move into an entrepreneurial role even while you were a surgeon? Was there a specific problem that you saw that you wanted to solve?
Yeah, great question. So I did I did 5 fellowships in posterior approach, direct lateral approach, and then anterior approach. Well, actually, when I met Michael Leunig back in 2008, I saw the surgery anterior approach being done at that time, and I was not very convinced of the surgical technique at that point. But when I saw the patients in clinic, one came in walking like you and me, say, okay, this is must be a preoperative patient. No, he's 4 weeks down the line. And I saw one patient after the other, after the anterior approach. You know how it is. They walk in normally, which I never saw in my fellowships, posterior or direct lateral approach.
Right.
Well, I did see those patients, but not with a high frequency as I saw it with anterior approach. So I fell in love with the outcome of the anterior approach, but not as much with the surgical technique. So then I called my promoter and I said, I'm in my doctoral, in my PhD, but I want to completely shift my PhD and I want to work on the capsular releases. So I started with the technique. I refined the technique. I refined the off-table technique. I refined the technique, and then I realized, oh my God, this is going to be a nice technique, but nobody will have 4 people around the table to do the technique, because that was one of the problems. We had 4 people around the table, 3 holding the retractors and 1 scrub nurse. That was not good. And then I said, okay, I need to do something about it. And then things started in my mind. You know what? You know how it typically goes. Then you go to one of the big companies and you give your idea, and they look at you and say, yeah, doctor, as long as you buy my implant. That's where it stops. Bye idea. If you have a really great idea, they will take your idea, they will patent it, and you lost it. Right. So I said, I'm not going to do it. You know what? I have a great idea. I'm going to find myself a buddy, and we'll start a company, and we will do it ourselves, because the big tech companies are not really interested in what's happening around the OR. They're just interested mainly what's happening with the implant. So, right. And then from one thing came the other. And then it started, and then I felt the energy of being an entrepreneur. So basically, why did I become an entrepreneur? Because, well, I think I've always been an entrepreneur, but it came out when I realized I had the problem. I saw a problem, and an entrepreneur wants to solve the problem himself. That's typical for an entrepreneur. You see a problem and you want to solve the problem, and you want to do something about it. One reason. And the second reason, Joe, and that's more and more how the older I get, the more I realize that it gives you freedom. Freedom. You take risk, but it gives you mainly freedom in what you do and how you do it, because you decide what you want. You decide on, okay, I no longer want to do my surgery with 4 people. I create a product, and then I can do it on my own. Bam. And I don't have to ask anybody anymore. Gives me a lot of independency, gives me freedom. That is what, and you know what, as doctors, we work in big systems, in hospitals, and let's be honest, we're not really free there, because you work in a system. Well, in the entrepreneurial world, it gives you really the joy and the energy of being free, independent, and do what you want.
How did your experience being a surgeon and in the operating room, how do you think that colored the way you approached being an entrepreneur or an innovator?
Yes. So in the operating room, I realized very quickly that my operating room in the beginning was not standardized. It made me very tired and annoyed, and it drifted away a lot of energy from me. And that is where it all started. And I said, I want to create a standardized environment in all different kinds of ways, because I want to be, again, more independent from other people there. I do not want to be dependent of all those nurses, hospital managers. So I want to create my own environment. I think I realized at that point that I love the anterior approach, but I realized that I could probably not continue with this approach as long as I needed 4 people in the OR. And now we're back in 2011. There was no pandemic. There was nothing. There were a lot of nurses, a lot of residents. Everybody was there. So there was a redundancy of people. But I realized at some point this would stop. And that I realized that I would have to stop this nice soft tissue sparing approach, which would take away the joy of being a surgeon. So in a certain way, I realized if I want to survive as a surgeon, I need to do something about it. I need to look at what is going to happen within so many years.
Hmm.
Of course, I could not know that the pandemic would come, but the pandemic now today has speed up that vision, because in 1 year time we lost a lot of nurses. In Belgium now we have a big problem with nurses in the OR, with residents no longer being there. And of course I could not know that in 2011, but I am very happy now that I felt that I had to do something about my problem of having too many people in the OR required to do my surgery.
Hmm. So you have historically, actually, we had a number of guests on the podcast in a row who all indicated spending time with you, right? To watch how you do anterior approach and watch how your workflow is. So teaching must have, at least at some point, been something that you found an interest in as well. And I wanted to ask you, in your approach to teaching outside surgeons who come in, do you feel like you're teaching the approach? Do you feel like you're teaching an efficiency workflow? Or is it some combination of those things or something else?
Excellent question. I'm not teaching an approach. I'm teaching a new vision on surgery, in my opinion. And the approach is part of it. The nice thing about the anterior approach, it's so a patient is supine. You don't have to install that patient. It's so the approach is really the anterior approach, in my opinion, is really the way to do it the most efficient way. So that was a nice plus. But I no longer teach really approaches. I try to bring forward my message and vision to surgeons. Think differently, disrupt. And that's where I fell in love with Anterior Hip Foundation back in the early days, in the really early days. That was in Las Vegas. I think it was 2015 or something like that. When I met Charlie the cook in 2013 or 14. And one way or the other, Charlie and I were really, really much alike. He said one day we're brothers from a different mother, because in one way or the other, he did the same thing on the other side of the ocean.
Yeah.
With the anterior approach, being very efficient. So he had the same ideas. And then at the Anterior Hip Foundation, I met Joel Mata. And for one reason or the other, from then on, I said, the Anterior Hip Foundation is the meeting where you have to be, because this is where the people are who think differently and no longer just talk about a approach. Because if you really look at it, Anterior Hip Foundation, we don't talk about the TFL. We talk about how we rethink surgery. And that is what I like about this so much. So, to go back to your question, I think I was very lucky to meet people like Charlie, who introduced me with Joel, and being able then to be invited to the Anterior Hip Foundation so many times. It was, and from one thing, and every time you go to the Anterior Hip Foundation, you come back with new ideas. I say, okay, let's try this out. And then I have another visitor and I tell them, look, this is what is happening here. And so when visitors come to me, most of them are selected. They already are, in one way or the other, they already know the anterior approach. So I don't have to talk about release. No, I bring them a philosophy of everything around it. And the efficiency model is a part of it as well. So and that's what I like the most, to try to disrupt a little bit, to be honest. Yeah.
So speaking a little bit about the Anterior Hip Foundation annual meeting, you've really brought some of that flavor of that meeting to Europe with your role with the European Anterior Hip Meeting. Just tell me a little bit about your involvement with that and maybe what inspired creating a meeting like that.
Yeah. Well, very simple. Anterior Hip Foundation inspired creating that meeting. And there is no such thing as a posterior approach community. There is a such thing as an anterior approach community. So anterior approach is something that surgeons who do the anterior approach, they like to rethink things. So, and when I was at the Anterior Hip Foundation, I noticed obviously there are a lot of Americans, but not enough, in my opinion, Europeans. There's still a burden or a threshold to go to Nashville, at that time to Las Vegas. And then Richard Field came up with the idea to start the European Anterior Hip Meeting. And then very quickly, in a couple of weeks' time, we had a faculty of extraordinary, very good surgeons. And all of them have been in the Anterior Hip Foundation. And then I asked Charlie and Joel, look, guys, would there be an opportunity that we, in one way or the other, that we combine speakers, faculty, and you were there last year as well, and you were a great speaker, and this year you will be there as well in 26. So, and what you see is that we, as from the Anterior Hip Foundation, a global community of surgeons who think alike is really growing. And for those surgeons who want to spread that message, it's not really a problem to go to each other's meetings, because we want to spread the message at each other's meetings. And you and I will go to Melbourne in a couple of weeks as well. So you see, it's a community that is created, and all the credentials to Joel and Charlie, who started with this, and then you also further spreading this all over the world. And I'm very, very honored and pleased that I'm a small part of that as well.
I think others would describe your part as being larger, but I do want to know, because the first European Anterior Hip Meeting was in 2025. It was in London. And I just want to hear, what were your impressions of that inaugural meeting? What do you think went well? What do you want to do differently for 26?
Yeah. So I wanted to take the Anterior Hip Foundation vibe to that meeting as well. But you have to know that in still some parts of Europe, and especially the UK, the anterior approach is very, very not well adopted. So
right.
Whether we like it or not, well, we like educating and talking about the approach, obviously, but we are still at the stage there where Joel and Charlie were about 12 years ago with the Anterior Hip Foundation, where anterior approach was at that point also not well adopted. So in the beginning, AHF also talked a lot about anatomy, talked a lot about surgical technique, more than today. Well, we are with the AHM where AHF was, let's say 10 years ago, because we have to now educate surgeons who heard about the anterior approach, but they really don't know the basics of it. So we have to do that at this point, because otherwise we will lose them. At the end, anatomy is everything. But what I want to do is more and more, I want to introduce other concepts, disruptive concepts into it as well, talking about technology more, talking about looking differently at how we manage our clinical practice, things like the hip cloud. And we want to introduce this more and more, but I guess you all also know it. European mentality is a bit different from the American approach to new things. So we have to approach it a bit differently in order to get it well adopted. So I think we will have to, with the AHM meeting, we will have to be a bit less disruptive and more steadily let the meeting grow than AHF was able to do in Las Vegas.
Interesting. So how do you see that meeting evolving over time? Not just the speed of evolution, but do you see it moving more towards an innovation platform, or more towards a direct surgical education platform, or what do you see?
No, an innovation platform. But as you know, introducing innovations in Europe is much more difficult than in the United States. So that's also something we have to keep in mind. And in Europe, surgeons are very well, how do you say, a bit more, they first want to, before they really believe it, they first want to see the results, rather than in America, when a surgeon, the mindset is different. The surgeon says, wow, this is great stuff, I'm going to try it as well. And the European would say, okay, this looks great, but can you show me how you did it? And they're a bit more slowly. So, which is good. I mean, I think both approaches are fine. But I want to see it more evolving towards, indeed, to more that innovative platform. But The UK is really a country where anterior approach, you really have to start with anatomy there. But not only the UK, you also have India, the ASPEC regions. They're also looking at it. So, and the nice thing about AHM, it's in London, which is really easy for American surgeons to fly in, and also from surgeons from other parts of the world to fly in. It's a bit more central, which I hope will spread the message of AHF even further.
Well, having been at the first EAHM meeting, I can say, I mean, I feel like it was a tremendous success for where you started. And, you know, your comparison to the AHF 10 years ago, I think I can see some aspects of that. But I also think you're starting a bit further ahead on the curve than even where the AHF was. And I'm looking really forward to what 2026 is going to bring for us. You've been really generous with your time. I have one final question for you, if you have time for it, which is you've clearly put a lot of thought into not just solving current problems and evaluating your current situation, but also being deliberate about the direction that things are going, looking forward into the future. So maybe I'm asking you to put your prediction hat on a little bit. But given what you've experienced over the last 15 years of your career, what's your vision for what hip surgery and maybe even specifically patient care around hip surgery is going to look like in the next 15 or 20 years? What are we going to be doing completely differently?
I think that with the anterior approach, I think we are reaching, from a surgical aspect, we're reaching levels where probably not a lot will change in terms of, I think we are reaching there really the summit of what we can achieve with the approach itself from a soft tissue aspect to it. Okay. Second, I do think that technology will change dramatically in terms of no longer will need big robots or fluoroscopy in the OR. I think we will be able to use just with a simple, let's call it anterior approach glass, we will be able to see what we should be put in, but this will be personalized based on outcomes that come from technologies such as HipCloud. I think we will be able to not only predict outcomes, but knowing how an implant should be put in what kind of a position it should be put in based on outcomes, not on x-rays. And we are obviously not there yet, but if you see how fast AI goes, I cannot imagine that it will take a lot more time, that the predictions of outcomes will be linked to implant positioning and implant parameters. And I like all the ideas about robots and everything we hear about technology, but so far I have not seen any technology that make this link of outcome, personalized outcome, and implant positioning or implant parameters. Unless I've missed it, but I haven't seen it anywhere. We talk about implant positioning separately from outcomes separately, but nobody really makes the really true link, also combined with the surgical skill of that personalized surgeon. Your data are different from mine. And we should be able, I think, if you really think, what I envision is that what we are developing with HipCloud or maybe other models that will personalize outcome, that it will merge with what we do in the OR. And when we do that, then we have nailed it. And I do not believe it's going to be robotic surgery. I think the surgeon will operate with robotic accuracy, but the surgeon will be supported by AI in the clinic to make the right decision for the right implant and then execute it with robotic accuracy. And we will we will go to that pathway, I'm sure. Because when I see now how the value is of that prediction model, it is still not linked with my implant positioning.
Mm-hmm.
So we have to make that link there. Yeah.
Well, Kristoff, this has been wonderful. I've wanted to have you on the podcast for quite some time, and I'm glad we could find time to do it. And I really appreciate you being with us and the insights you've been able to share with our listeners today.
Thank you, Joe. And I'm looking forward to see you in the future meetings and to have a good glass of good beer or good wine the next upcoming meetings of AHF, AHM, and in Australia.
That's all for today's episode of the AHF podcast. If you found value in this conversation, share it with a friend or colleague, or just drop us a comment to let us know. And make sure to connect with us on LinkedIn to join the discussion between episodes. There's a link to our brand new LinkedIn page in the description. Find us every Friday with new episodes on Apple Podcasts, Spotify, YouTube, and all major podcast platforms. I'm your host, Joe Schwab, reminding you to keep those hips happy, healthy, and maybe on a cloud.